So today we're providing an introduction to two important topics that members often ask us about. Firstly, we'll cover thermostatic dysregulation and how to stay warm in winter months. And then we'll look at some of the common comorbidities seen alongside ME, often described as the Septad or the Pentad. So firstly, let's look at thermostatic dysregulation. This is a real physiological symptom linked to autonomic dysfunction and neuroendocrine instability. It's not poor circulation or just feeling cold. We'll provide some practical strategies for dealing with fluctuating temperatures during colder months. So what is thermostatic dysregulation? Your body's thermostat isn't regulating properly. These symptoms, it's a systems level issue. Many people experience both cold intolerance and heat sensitivity because the system is unstable, not just low. It is common across all severities of ME. It can feel like having cold extremities, but a feverish torso. Being able to regulate your body temperature, experiencing night sweats, and intolerance to the extremes of heat and cold. And why is it happening? I mean, this is not a circulation problem, but a regulation problem. So it's well recognized in research literature. Thermodysregulation is linked to the broader pattern we see in ME, such as heart rate variability, gastrointestinal dysmotility, and orthostatic intolerance. Essentially, the internal thermostat is, for want of a better word, wonky or impaired. Winter is a stress test for an already unstable system, so even mild or cold exposure can trigger PEM in some. Feeling cold all the time is not a personal failing, it's a physiological response produced by a dysfunctional autonomic nervous system. So cold increases muscle tension, pain, and sensory hypersensitivity, but heat can cause vasodilation and worsen your orthostatic intolerance, dizziness, nausea, and cognitive impairment. Both of these can precipitate PEM. This means that temperature stability is a safety measure. So what can we do? Many with ME find it easier to warm up than to cool down. So using layers of clothing enables you to modify temperature as your body adjusts. Several lightweight tops is better than one thick jersey, for example, so that layers can be removed or added as needed. Of course, when using any heat source, avoid direct skin contact. Small changes can make a big difference because the system is so sensitive. So try different strategies and see what works best for you. Most thermostatic dysregulation, despite being uncomfortable, is benign. However, there are red flags that will warrant GP review. This is things like persistent inability to warm up, blue or purple extremities, or extremely white fingertips with pink finger and hands, shivering that doesn't stop. If your OI symptoms get very pronounced in the cold, especially dizziness or fainting, all of these warrant speaking with your GP. So cost of living pressures are normal for many of us with ME. So it is important to contact support services if you have concerns about heating costs, such as WINS, electricity retailers for payment plans, or hardship grants. Thermodysregulation is just one part of a broader pattern we see in ME. So next, we'll look at the Septad and the Pentad. It is important to understand that ME rarely occurs alone. The terms Septad and Pentad are a pattern recognition tool rather than diagnostic labels, but they can help people understand their symptoms and comorbidities in a validating, structured way. This is based on emerging research and clinical observation, not speculation. The Septad-Pentad is a way of describing the conditions that frequently travel with ME. This is not about collecting diagnoses, but rather recognizing patterns. Some people may experience all of them, others only two, and others may not experience any of them. But they are a cluster of conditions commonly co-occurring with ME reflecting shared pathophysiology. So it's helpful to know that there are actually two different constellations used in clinical practice. The first comes from the ME research world. When researchers look at large cohorts, they consistently see 5 conditions that cluster with ME more than any others. That's fibromyalgia, POTS, migraine, IBS, and either mast cell activation syndrome or hypermobility, depending on the study. This is often referred to as the ME Pentad, the ME-CFS Pentad. The second constellation comes from the broader clinical community. This is the version many of you will recognize from your own lived experience. Includes dysautonomia, mast cell activation syndrome, hypermobility, GI dysmotility, autoimmune conditions, chronic viral reactivation, and neurological structural issues like small fiber neuropathy or craniocervical instability. We're seeing groundbreaking emerging research, including from New Zealand researchers, highlighting strong overlaps between ME, CFS, endometriosis, and neurodivergence, such as autism and ADHD. These patterns suggest a shared underlying vulnerability in immune, connective tissue, and sensory processing systems. Post-COVID, we've seen a marked rise in new onset hypermobility and Ehlers-Danlos diagnoses. Compression syndromes are increasingly recognized in patients with hypermobile Ehlers-Danlos syndrome and dysautonomia, both of which are common comorbidities in severe ME. While formal prevalent studies in ME are limited, the association is well documented in the hypermobile EDS literature. So this broader constellation is the one we see most often here in Aotearoa, and it reflects the complexity of the people who come through our community. So today I've introduced both, but we'll focus on the version that best matches what we see in New Zealand. So these conditions cluster because they share deep biological roots in autonomic regulation, connective tissue integrity, mast cell behavior, immune signaling, and neuroinflammation. We also see strong overlaps with endometriosis and neurodivergence, as just mentioned. This is suggesting that shared vulnerability in immune, connective tissue, and sensory processing systems. So it's not a coincidence, it's a recognizable, research-supported pattern. These systems interact. So one is unstable, others often follow. So these occurrences are not rare, they're not coincidence, and they're not psychological. This clustering is seen internationally and across research groups. Post-COVID, we've seen a marked increase, as I've mentioned, in people developing or worsening hypermobility, dysautonomia, and mast cell activation syndrome. So this is not a fad, and these conditions are not new, but rather it reflects how the COVID-19 virus affects the connective tissue, vascular tone, and autonomic regulation. For some people, COVID doesn't create these vulnerabilities from scratch. It reveals them or unmasks them. Most commonly, it's dysautonomia and joint instability. This broader constellation helps make sense of why so many of you experience symptoms across multiple systems. It's not random and it's not too many diagnoses. It's a shared biological pattern. Understanding this can make clinical conversations easier and reduce the sense of confusion or self-doubt. It also reinforces why ME care needs to be multidisciplinary and patient-centered. And here's what ANZMES is doing right now in this space. So we've already integrated the Septad Pentad into education modules in the No ME clinical education program, because this is that broader constellation we see in New Zealand. We're part of a study group of clinicians and researchers who are actively examining these patterns, including the overlaps with endometriosis and neurodivergence. We're also strengthening our links with both New Zealand and international researchers working on these shared biological pathways. And through the long-term Conditions Coalition. We're aligning our advocacy with other organizations to push for multi-system, multidisciplinary care pathways because this constellation cannot be managed by a single specialty care. Looking ahead, we will develop new modules on dysautonomia, MCAS, hypermobility, and GI dysmotility and related conditions, which will include clinician-ready resources to help health professionals recognise multimorbidity earlier and more confidently, and a member-friendly explainer so you can understand this constellation in a clear, accessible way. All of this is part of our ongoing commitment to education, advocacy, and research partnerships, making sure the New Zealand experience is visible, understood, and acted upon. So we hope you've enjoyed these short presentations. We will, as I said, make them available on our YouTube channel in due course for you to review at your convenience. And you can find a link to a one-page summary of each talk in the chat box. We would like to thank you for your time today. Are there any questions before we finish up?
I had a question about CCI in New Zealand, obviously, if that was possible to ask.
Can you say again, sorry?
I had a question about CCI and our patients with suspected CCI because obviously it's incredibly problematic. There's no facility for diagnosis in New Zealand, etc., etc. It's very limited. Do you have any advice for patients that we might suspect could have issues there and what we can do around that?
Well, as you pointed out, there is no real diagnosis in this country, and we have this issue where the standard practice for MRIs are those fixed ones, whereas to actually recognize it, you need to have the flexion extension and ideally functional MRIs. So they're not done routinely. My advice would be to go to find physios who have a clear understanding of it and work with them because they're going to have more understanding about how to support that instability. The instability usually occurs within the muscles deep within the neck rather than the external ones that you can feel.
Yeah.
And so if you can strengthen those ones on the outside through small over time resistance training through physios who understand it, that can help with that instability. There are also other things that they can do, like literally wearing neck braces to actually just help with that instability, making sure that they fluctuate between having rest, so leaning against supportive pillows, versus sitting upright and letting the neck hold the head up. So you can only do that for a short period of time before those muscles fatigue. So it actually helps people to have that supportive pillow behind, so leaning back onto a supportive pillow. It's just little strategies like that can help the lived experience. In terms of clinical practice, New Zealand is still catching up with overseas on that. And so it'll be part of the connections that we're making with long-term conditions and clinicians and the research that's coming through, and the more of them that understand it, and the more then they will start recognizing it and speaking with their counterparts about it. And from there, we hope we will get some more understanding clinician-wise and in the health system about it.
Question about the MRIs. You say I had heard that there was one in Wellington actually that had capacity to do upright, but I don't know if that was just that was actually fact or fiction. Do you happen to know about that?
I'm not sure specifically, but the thing is, there is capability within the country, so it is just finding the right ones. If there is one in Wellington, that's great. I don't know personally, but it's just a matter of it's around like clinician training, and the equipment that they've got and how to assess it. But yeah, I'm not sure, but we can find out and see. I can get back to you on that.
That'd be great. Thank you so much.
No worries. Thank you. Any other questions?
Yes, I popped a question in the chat. Who are the members of the Long-Term Conditions Alliance that you're working with?
Um, there's Arthritis New Zealand, stroke, epilepsy, us, and autism, the Neurological Alliance, and then some of the other organisations that are part of the alliance are also involved as well. So that's the Long-Term Conditions Coalition, and then we also have a grey areas, for want of a better term, collective, who were working together through the Whaikaha Advisory Panel a few years ago. So that includes Ehlers-Danlos, Tourette's, autism, ADHD. Again, they all overlap. So some are members of the Neurological Alliance and so are included under that representation umbrella, and others join as an independent organisation.
Thank you.
Any other questions? No? Okay. Well, thank you very much for your time today. Ka kite anō. I'll leave you all to get back to your days. Thank you so much.